Maine. What is up, everyone? That's me, Haney Malmet, even though the name is over there, and that's Adam Green. We're having a little technical difficulties tonight, but it's all good. What is up, my man?
Not much. I'm in the middle of a tough ICU stint, but I'm excited for tonight. Hopefully some education and some comedic relief, right?
Yeah, you told me this was 36 of 37 for you in the ICU.
Yeah.
Day 36. It feels that
37 of 36. I did a couple days in one.
Oh, wow. That's pretty impressive. Yeah. Do you find that after how many days do you get a little crispy? Like, does the usual seemingly benign, hey, can I get a Tylenol order become, I'm going to kill you? What day is that for you?
Probably depends. It just depends on a lot of things, right? The acuity, who you're working with, kind of how stressful the situation is. I do think there's some really interesting things looking at how many days in a row can you do. And I think the optimal number is maybe 4. Then you start to get a little cognitive decline. But the problem is then if you're only doing 4 days or 3 days in a row, then you have to do a lot more segments of shifts. And we all kind of enjoy our time off. So I don't know.
Yeah. It's also hard to build rapport with family. That's one of the things that I think critical care is great if it could be compartmentalized into shifts, but learning people's families, building a rapport, it's a difficult thing. So I would say for day 5 to 6 is where I notice a little bit of crisp to my voice is what I see.
Agreed.
Well, we're here tonight with some special guests that we'll bring on in just a second. If you are new to Critical Care Lounge, welcome to the lounge where we just lounge and we lounge in. We talk about issues in critical care. We talk about the gray zones in medicine, the things that you're not going to find in textbooks, and we bring experts on to help us along. So if you're new, welcome. Don't forget to subscribe to the channel, like this video. If you like it, hit the dislike button. If you dislike it, do something. Just let the algorithm know what is going on, and we appreciate all of you being here. Let me get this screen off. And let's see. We asked a couple people where they're writing in from. We should give some shout-outs. Should we, Adam? You want to go ahead?
Absolutely. So looks like we got a Philly. We have a Granada Hills, California. I wonder what part of California that is. Ukraine, Fort Wayne, Indiana, legit. All over the place. Bunch of New York, it looks like. That's
Upstate.
Great.
A lot of upstates. Wow, the algorithm must be hitting the Albany area for some reason. Look at that. Vermont, Albany. All right. We did something right in upstate New York. The Adirondacks. All right, so let's kick off the show, Adam. Well, you read correctly. Today we are talking about transesophageal echo, or as they say in Australia, TO. TO. Did you know that? They call it TO?
I didn't know that. Get out of here.
Esophagus is spelled
TOE.
You
got it.
Right? So there you go. Okay. Adam, you want to introduce our guest tonight?
Sure. So two real all-stars. Both Cooper trained, both ER initially. So we have... I guess, do we pull him in? We have Chris Noel, who's the APD at the Critical Care Fellowship, and look at him. He's truly lounging outside, the first outside lounger, I'd say.
That is true.
And to the left, what's his name? Don't call me Coach. Michael Coach.
Don't call me Couch.
Right. Don't call me Couch. I don't know what to say about him, but he's the man. And I'm just excited to have you guys on. And this, I'm going to admit, before we even get going, I'm going to admit this is by far the topic I know the least about. So I'm going to talk a lot right now because probably the most of the episode, I'm going to just be quiet and trying to soak it in. So I'm really excited. Thanks for joining us, guys. This is where you say this is you're welcome, or you say something nice. Like,
we'll walk you through the process of lounge. It's very easy.
Yeah.
They're smiling okay, but now we just have to prompt them.
Are they muted?
Are they muted? Oh, you know what? They may be muted. Maybe they were talking the whole time. Oh, jeez. That's a rookie move. All right, let me get this going. Let me see. Oh, I know what's going on. Hang on. Some people think these are technical difficulties. We do this on purpose. I mean, this is just to all right. No, they should be on. You guys there? You guys there?
Nope.
That's interesting. Now that part I can't figure out why we can't hear them. Interview is on.
Is it muted on their end?
Let me try one more thing. Let me have one more trick up my sleeve. How about now, guys? It's funny because I'm talking to you. You guys have yourselves muted. Do you see the
Mike
mute
says
button?
no.
Huh? No?
They say no.
Huh. It says it's muted on my end. I don't know. Why don't you guys log off and log back in, and then we'll go from there, and I'll go back to Adam and me, and we'll kind of talk about give people an idea of what we're talking about today. We're talking about transesophageal echo. How's that now? Can you talk to us, Mike?
Yeah, it should be good. It looks like
there it is. There he is.
Oh, there we go. Whew.
There we go.
And then Chris will jump back in. So I guess we'll start off with you, Mike. We're talking about transesophageal echo, and it's something that, in full disclosure, I'm very, very passionate about. And I've been trying to spread the word, but it's funny how I got involved in it. No one wants to hear my story. How did you get involved in transesophageal echo? How did it become a part of your practice?
So back when I was a second-year fellow, we started studying for the echo boards. And really, I went through most of that studying having no understanding of really what I was looking at with transesophageal echo. And then we started to use it a little bit, as more of our group became boarded, and obviously you and Sharad Patel and Nitin Puri were really into using it. I remember looking as a second-year fellow and thinking, I have no idea what is on that screen. And I don't know, call it passion for the job or my ego. I'm not really sure which was winning that day, but I just decided that I wanted to learn it. And so we really just got involved in it and started to learn more of it, day by day. And now we're probably 3 or 4 years into the program, and the fellows are learning faster than ever. I mean, it's incredible. They pick up TEE as fast as they're picking up transthoracic echo. So it's been a really incredible journey.
Yeah, let me get you back on here. Yeah, I totally agree. And it's definitely one of those skills that you kind of hear about in the periphery. You can go through a whole critical care fellowship and not hear about transesophageal echo being done by intensivists or even the desire to do it. And then there's some places that are really ahead of the curve who are saying, you have somebody who morbidly obese or has a lot of subcutaneous emphysema where you're not going to get a good window. Of course, it's in the intensivist purview. So that's great. Let's get Chris on here. And Adam, you want to get the next question ready?
Yeah,
Chris,
Mike, you said something. Oh, hey, Chris.
Sorry, can you hear us?
Yeah.
Can you hear it?
Yeah, there he is.
Perfect.
All right,
Great.
Good. I'll take this opportunity to open my drink. All right.
So
go ahead, my man.
Again, Diet Coke, of course.
Yes.
Only Diet Coke.
Let's go.
So, Mike, let me ask. You said something that was interesting. I always figured the best way to be good at TEE is to be really good at TTE. And you just kind of mentioned the way you said it. It almost sounds like there's skills that you can learn in parallel. Do you agree, or should everyone just start with basic TTE?
So I agree and disagree at the same time. I mean, I really think it's whatever works for you for really understanding it. And it comes down to access. If you don't have access to TEE, it can be difficult to learn. And so starting with transthoracic echo, it gets a great foundation that you can build TEE right upon it. So if you really think about the two modalities, transthoracic echo is just looking at the heart anteriorly from the chest wall, and transesophageal echo are very similar views, just looking from behind the heart. So all the views are just mirror images of each other. And the secret is that transesophageal echo is often easier to learn because the images are just that much clearer. And so if you can conceptualize the anatomy, I think both you can learn hand in hand. The problem with it is when you try to go 0 to 60 on it right away, where you haven't set a good foundation and understanding what am I looking at and why does it look that way, versus just trying to open a textbook and memorize images, which was really how I started, and it was faulty. And then when I started to learn it from a more anatomical approach and just trying to demystify something that I thought was so complex, it became more and more simple.
And
that makes
Chris,
sense.
we started off asking the question, what made everyone interested in learning TE, and that was when you were off air. What was the inspiration for you to make you learn TE?
Yeah, so I mean, I think it was a couple things. One is, there's certainly that subset of patients where that if you were able to get images, it would really help to guide your management. But if you can't get the views, then TEE is the only way to get them. And so that was one motivation. And two, certainly there's patient populations where transthoracic is not going to give you the anatomy that you would see on TEE. So cardiac surgery would be one example where they can have a focal of issues that you wouldn't necessarily pick up.
Yeah. Gotcha. I have a question, and it's a question that I've experienced a lot in my career learning transesophageal echo. What is your response or what is your stance when people say, oh, that's just the cardiologist who should be doing TE. That's just the anesthesiologist. I mean, certainly it's easy to kind of flex back or, and take that position. But from a diplomatic point of view, how do you talk to the stakeholders like the cardiologist and the anesthesiologist in the hospital and tell them that this should be in the intensivist purview of care as well?
Yes, those negotiations haven't really been too complex for us, to be really honest with you. First off, if from a political standpoint, if you lead with, I'm not taking away business from you, it makes the conversation a lot easier to even start. We're not doing transesophageal echo to assess for severity of aortic stenosis unless it's clinically significant, or we're not looking for severity of mitral regurg or preoperative planning. We're looking to answer an urgent or emergent question that we need in seconds or minutes. And, you can be passive aggressive and say, listen, if you're willing to come into the ICU at 2:00 in the morning and obtain these images for me so I can appropriately care for this person, then we don't need to do transesophageal echo. But if that's not a possibility, then we need this critical tool to care for our patients. And that's how you have to think about it. It's a tool that we need very quickly to make life-saving decisions. And we haven't really had any pushback from any of our consultant services. In fact, I think they like that we do it now because, number one, it makes their lives easier. And I actually think it probably increases the amount of echoes that we're ordering through cardiology, or TEs, transesophageal echoes that we're ordering through cardiology, because we're seeing these problems where we may have not recognized them before, and now we're facilitating that workup.
What about you, Chris?
Yeah, I agree, Mike. Yeah, I agree. I think one thing that's not often mentioned is just how much it increases the collaboration. And there's been many a time where I've called my cardiologist and said, hey, I'm doing this TEE. Do you want to see it on a patient that we're jointly managing? And it's been nothing but helpful in bouncing ideas in terms of the hemodynamics and the technology of what to do best for some pretty complex patients.
That's great. So let me ask a question. Kind of along the same lines. I think most of us familiarity with TE is it's just used to rule out endocarditis, and I even think some of us think that it's a superior TTE. So can you answer me this? Are there indications where you think that TTE is still absolutely superior to TE, or is it always just bigger and better? The answer
Chris,
could be that TE is always better. I don't know.
I mean, I think one of the things that Mike touched on earlier is, ease of access and the speed with which you can mobilize this, depending on your resources and, how many probes you have, who is available to do it. And, the TTE is always great that you don't have to really select patients, bring it to the bedside. Whereas TEE, there's certain patient populations. As intensivists doing it, it may not be as accessible. So let's say you're anticipated patients.
That makes sense. Okay, then let's jump into. Oh, go ahead, Mike. Sorry,
Chris. I tell you, there are a couple pathologies that I think are better on transthoracic echo than are on transesophageal. So kind of bigger is not always better in this scenario. If you're looking at tricuspid regurgitation, it's very difficult to line up that tricuspid regurgitation jet with the transesophageal echo and get an adequate reading. And so that's one of those classic pathologies that's difficult to assess with transesophageal echo alone. The other thing is when you're looking at the right ventricle, sometimes that view on through the at the esophagus level is a little bit limited, and you can't line everything up perfectly, so it's sometimes hard to truly assess RV function with transesophageal echo. And so those are two scenarios where I think if you can get great views on transthoracic, that's great. If you can't get those views and you need to use transesophageal echo, sometimes beggars can't be choosers. We can't get views across the chest. And so that's where TEE for me is really helpful.
And let me follow up with that too. How, we know about the complications of TEE. Yes, practically you have to go get a probe and consent, where transthoracic you don't need consent, but there are some complications that can be associated with TEE. And my first question is, what are those complications in order of most likely to least likely? And then my second question is, are there ever any true contraindications to someone getting a transesophageal echo?
Sure. So remember, we're putting this probe through someone's oropharynx into their esophagus. So the simplest way to think about the contraindications or the risk factors or the complications are anything within that area. So oropharyngeal bleeding, GI bleeding, you can have esophageal perforation theoretically. When you look at the numbers are pretty low, all complications, and that includes transient hypoxia, even during this with non-intubated patients, is only about 2.8%. And that's all comers. But when you look at the complications when someone's intubated, you're talking less than 1% complication rate. And so it is very, very well tolerated, but it's the GI manipulation that's often the most concerning thing that can go wrong in the case. So anytime someone has previous GI bleeding or has esophageal varices, these are relative contraindications. And if someone's having active GI bleed, obviously, or esophageal perforation or esophageal pathology, Zenker diverticulum, things like that, those are patients who just can't obtain TEE unless you had GI come and scope them and say, okay, that pathology is all cleared up, you're ready to go.
Yeah, it's it's almost as if you had an ultrasound guided TE insertion, and you'd be totally in the clear.
So I'm hearing bleeding is probably the most common, and then some sort of injury being the least common but most deadly. So what are I think Haney asked, what are the absolute contraindications? I guess you mentioned that would just be basically esophageal pathology. Let me ask, who do you actually do it on then? What are you already mentioned those that you can't get TTE and you really need better views for their hemodynamic assessment. So who are the ones that you find most commonly grabbing the probe and ultrasounding?
And Adam, I just want to go back to what we said. It's like anything we do in the ICU, right? It's risk versus benefit. The
Right.
patient we're grabbing this to do this on, they're often in extremis, and so some of these relative contraindications, which you may read about, they're really pertaining more to the OR setting. Certainly, if you need the image to take care of your patient and make a diagnosis, it could change therapy drastically in someone who's it changes the.
Actually, Chris, that's what I should have asked. I should have said the most common thing I get from cardiologists when I ask for a TEE is that they're too unstable, which I find funny because it sounds like the patients you guys are describing are too unstable, and that's why you're doing it. So that seems a little counterintuitive, right? Mike, you're smiling. You got something, right?
Yeah. I think everything that we do, it's those patients who need sedation or need any procedure. We're doing them when there's a very high chance they're going to die with or without that procedure, and so it just falls into our wheelhouse pretty well. All these patients are intubated. I think that's an important part to make sure we comment on that. In the ICU, I can't think of a case that we've ever done a transesophageal echo on a non-intubated patient because that's not the patient population we're looking at. And so you can place this via glide scope visualization of the esophagus, right? And you can insert jokes here about esophageal intubation, but it's a really sick patient population that if you don't do the procedure and you don't have the answer, that they're not going to do well. And that's where this really comes into play. It's a tool that I can't imagine not using anymore. I mean, I think that's an interesting thing. Before using it, I couldn't imagine doing it. Now I can't imagine going to an institution and not having it.
So let me ask you guys, when have been some cases where transesophageal saved the day? And I bring that up because there's probably people on here who feel very good about doing transthoracic. They're very good at it, and they're like, why do I have to add something else to it? There are people here who know they're going to be blocked by their cardiologist and intensivist. But I think what would be helpful is if you both give us maybe one or two cases each that truly saved the day, that truly changed management, that you tried with transthoracic first and it just wasn't working. Chris, do you have any one of those?
Yeah, so I think one of the patient populations I mentioned, which is extremely helpful, and is post cardiac surgery patients, where having had a sternotomy, having entered the chest, you often have little or no view from a transthoracic standpoint. Due to air artifacts of things. And so these patients are certainly at risk for bleeding, and not only just bleeding, but clotting as well, and clotting in ways that you wouldn't expect in other patient populations. So, for example, tamponade. We often think about tamponade as a circumferential pericardial effusion. You can see it very clearly on TTE. In the cardiac surgery patient, that can be a very focal tamponade. Focus right around the left atrium or the right atrium, that you may not be able to see from transthoracic, and even if you had good views, you wouldn't be able to see well. And so, that's a patient population I think really benefits from this. One case that I had in particular was a patient with prosthetic mitral and atrial valve who had bleeding and then stopped bleeding and kind of was somewhat stable at that point. And but because we were able to do a bedside TEE, we put the probe in and we saw very large hematoma compressing the SVC as well as the right atrium that we weren't able to see from transthoracic standpoint. And the patient would likely not have gone to the OR for a much longer period of time and in much more profound hemodynamic compromise than when they did go to the OR. What they actually found was that there was a breakdown of the patient site from bypass.
Great case. How about you, Mike?
We had a case about a year and a half ago of a gentleman who was a pretty young guy. He was in his 30s and he was about 700 pounds. He was transferred to us with severe ARDS. That's a really tough patient population because you're flying blind a lot of times because you just don't have imaging. Can't get a CAT scan. They certainly can't get an MRI. And he was encephalopathic, and his LFTs kept rising. And because of his severe ARDS, he required anywhere from 16 to 20 centimeters of water of PEEP. And he started to get progressively more hypotensive, and we really didn't have any answers because we didn't have any objective data. So we did a TEE on him, and we found that he had acute right heart failure, RV dilation, which was ultimately causing liver failure and hyperammonemia. So it would have been very easy to have attributed to his ammonia levels, his liver dysfunction, to liver or medications, but it was actually all pulmonary hypertension. And so we actually placed him on CRRT and started pulling a ton of fluid off of him. Interestingly, I know we're not talking about other ultrasound, but his optic nerve sheath was dilated and looked like he had some cerebral edema, and that all got better as we corrected his right heart failure and adjusted his PEEP based on what his right heart could handle. Because all that intrathoracic pressure was doing him some harm, and so we found a good balance for him. So it was really a lifesaver in that case.
Yeah, great examples, and maybe if we have a little bit of time at the end, then we could talk a little bit about maybe how it's helpful in cardiac arrest. I think that's one of those areas that emergency medicine is pushing, but certainly very, very helpful intra-arrest management using transesophageal echo. Adam, I'm going to let you ask a question. I'm just going to remind everyone, please hit like if you like the content you're hearing, subscribe to the channel, and please, most importantly, put your comments or questions in the chat so when we get to Q&A, we can address them. This is not something that everyone is 100% on board with in terms of transesophageal echo, and that's exactly why we're doing this show, to get people excited about it, and for those who don't really know much about it, to get them excited so that they can start to learn this and add it to their skill set. What do you got, Adam?
Yeah, that's a perfect segue to my next question. So, I think there's probably going to be those. I think we see in the comments some people saying, "Let cardiology do TEE," and I think it's some institutions that's probably the right answer. But let's say, guys, you hear the show, they look at you two, they're like, "Man, I want to be like them. That's exactly what I want to do." And let's say that they don't have the support, they don't have the Dr. Knowles and Malamats and people sitting around ready to teach them. How do they get into this? I mean, they've expanded, they've learned TTE. How do you guys suggest people acquire the knowledge? Are there resources that you should go to? What's the next step to the person who just truly wants to get these skills?
Is there a TEE school?
Yeah.
School of Hard
Yeah,
Knocks,
it's called
the TE School of Hard Knocks. If your institution has,
it's called ultrasound.
Shout out, thank you.
If your TE, if your institution has a lot of camaraderie, right, you can get in the operating room with your anesthesiologist, right? Particularly if you have a cardiac surgery program, and they're a really great resource, and they're always happy to teach. And I think just describing to your colleagues why you want to do it, and that it's actually going to help with faster diagnosis and potentially make their life a little bit better. They may be interested in teaching you. There are courses out there that are really helpful. I think Resus TE, right, is one that's pretty good. But there's also websites. If you search Toronto TE simulator, you can find a free simulator online to get the views. So at least that's a good place to start. But you really have to learn either on a true simulator or with a patient and with an expert, I think.
Chris, what resources
Yeah, and
are you using?
I think, sure. I guess, to what Mike was saying about get to know people, I think that's the key is, there's going to be people who are more obstructive than others. So letting this happen and getting to know them, getting in their wheelhouse and, showing your interest and why you're interested, I think is really helpful. For me, I fortunate enough to have access to a simulator after some witnessing and then shadowing and then patients, and the simulator was extremely helpful. Very helpful as well. But I'm also a textbook guy, so make it actually take.
What was that you said? What's that word you used? Text.
Paperback.
It's like a podcast, but on paper.
Oh, okay. Podcast. I know that word.
Yeah.
Yeah, that just reminds me. I thought it was kind of along the same lines. I was helping a ECMO patient who was doing poorly, and I brought him to the operating room, and anesthesia was there, and someone said, get me the ultrasound probe. And I'm like looking, and like the whole surgical field's on the chest, and I was like, where are they going to put the ultrasound? And I'm like looking, waiting for the mind ray to come. And then I look up and I realize that they just put a TE probe in, and it was just sitting there. And for the majority of the case, they just had constant view. And it was just amazing to me how quickly and how easily and how efficiently they did it. And so it just reminded me that that's probably a wonderful place to like get hands-on experience for those that are just trying to acquire the skills. Haney, what should we do next? Do you want to talk? Do you have another question?
Yeah, I was going to ask about basic views, because anyone who's done TE or shadowed a cardiologist or anesthesiologist knows there are many, many views, over 25 views that you can look at. The first question I have for both of you is, do you need all those views? And if the answer is yes, well, then that's good. But if the answer is no, what are the minimum amount of views that you would recommend for an intensivist or even an emergency medicine doctor who's doing resuscitation, what's the minimum number of views that they should know? What do you think, Chris?
And do me a favor, don't just say something like apical 4, because that whatever the names you're going to say, I'm not going to understand. So can you actually describe what you're looking at?
And don't say anything from a textbook because I won't understand.
Yeah.
Yeah. So I mean, I think the easiest view to get, and kind of we often talk about it as a home base, is your mid-esophageal 4-chamber view. And so what is that? Essentially you're seeing all 4 chambers in anatomic form. It's kind of the most conceptually, I think it's the conceptually most easiest to understand what you're looking at. So you can get a good sense of the chamber size, gross chamber function. You can see if there's a large pericardial effusion. A lot of pathology can show up right there. So I think that's one of the key views. The other, key view, particularly if you're looking at, LV function of wall motion abnormalities going into your transgastric short axis. And there you're going to see your LV in short axis and be able to see for any focal wall motion abnormalities, so like you would transthoracic in your short axis.
Well said. Adam, you got any other questions?
I think the only thing I had left was just talk about in specific scenarios. And I know we've kind of mentioned it. So I don't know if there are cases or if you have other videos. I don't think that part was working. And so the 3 I highlighted, maybe we can just talk about them. The 3, we talked about cardiac surgery patients. How about the use in aortic dissection? And is there a specific role for TE in aortic dissection?
Chris, you want to start with this one?
Yeah.
Yeah. I think certainly. I mean, I think about your patient who's too unstable to go to CAT scanner, right? You're trying to see if there's something that potentially you could fix, that you could reverse, or maybe a patient who's in cardiac arrest with pericardial effusion. And I think either whether your answer is that there's something to try to go after and fix, or this is too far gone, we can't fix it, is always another helpful piece of information. As you're doing a TEE, right, it's going to give you that great view of your proximal aorta, your ascending aorta, whereas TTE is often limited in this case. And similarly with most of the proximal arch, and then the descending aorta as well. Where you have limitations is in kind of the distal aspect of the arch. So you can have a blind spot with respect to dissection, but for the most part, for a clinically significant dissection that's causing your patient to decompensate, you'd expect it to span, that area.
What do you think, Mike?
Yeah, I think when you're aortic, you're coming from the esophagus, and when the trachea gets in between, or your left main bronchus gets in between the esophagus and the aorta, that's where you're gonna have a little bit of a blind spot. So there's some limitation. I think this is a really good example to highlight how important transesophageal echo is, but also needing to know when you don't know something, right? So you may miss a blind spot, number one, and we have to always be humble with that. But while the sensitivity is really high, you're above 95% with a sensitivity for diagnosis of type A dissection if it's present. The specificity is relatively low. It's really only about 75%. And so that's probably because there's artifact. So there's findings that look like dissection flaps that are actually the atrium, the wall of the atrium, that looks like it's an artifact within the aorta. And so whenever you have someone, there's a incorrect or a false positive diagnosis with transesophageal echo, that's usually the case. Either you have this abnormality that's not a true abnormality, it's an artifact, or you missed the start of the dissection in the blind spot, which I think is probably pretty rare, which is, I think, marked by the sensitivity being so high. But in those people who can't travel, it's the best you have.
Yeah, well said. There's so many patients that we have that we can't get them in the elevator to go to radiology. And for some people, it's like, well, that's what we can do. transesophageal gets you some of those patients back, some information back on them for the RV that you can assess, the pulmonary artery if you're concerned about an extensive clot in there, and then certainly for this, the dissection flap. So I personally don't think it's one of those things that's like it will help you with every aspect of your care, but once you realize how minimally invasive it is, how safe it is, how good the images are, how easy it is to do, it's one of those things when I started doing it, I was like, why are more intensivists not doing this? It just makes sense that we should be doing it. And like you all said, this is not something that's going to replace the classic cardiology or anesthesia TE. This is its own section carved out for critical care, a very focused exam to ask a specific question and get that specific answer so we can keep resuscitating those patients. Great. Are you guys up for taking some questions from the audience?
Well, Haney, actually, I want to put you on the spot because you've mentioned cardiac arrest multiple times, use of it in cardiac arrest. So I'm sure you got a spiel on that. But
this show's not to interview me. I'm not.
Oh yeah, but I'm doing it. What do you think the role of TE is for cardiac arrest?
Well, there's lots of benefits in cardiac arrest. When patients come in cardiac arrest, we go through the H's and the T's, and I'll be honest with you, I think it's just an academic discussion. You go through all the things that it could possibly be. I'm a big fan of using ultrasound in all cardiac arrests, but if you can use transesophageal echo in your arrest, a couple things are going to get better. The first is we realize that when you're doing transthoracic echo, there's quite a bit of pause that happens when you're looking for images. We say the rhythm check should be less than 10 seconds. There are studies that show that when you use transthoracic ultrasound, it's over 20 seconds, sometimes, up to 40 seconds. Really dangerous numbers when you should be back on the chest. Realize with transesophageal echo, not only can you minimize that rhythm check because you don't have to line up your image when everyone's feeling for a pulse, the image is right there in front of you. But during chest compressions, you can be evaluating the heart. You can be looking to see if there's tamponade. You can be looking to see, if there's a dissection flap happening during that. So you can be doing stuff while people are doing CPR. So that's one thing that's very helpful, looking for reversible causes. The other thing that's beneficial is it can guide how well you're doing CPR. Everyone thinks that if you're pushing on the sternum, 2-finger breaths below the manubrium, everything is good, but there's data that shows that people's hearts lie differently and that AP compression is not always the same for every patient. So imagine, if you will, having a transesophageal probe in during CPR and being able to look and say, wow, we're actually not compressing, in a anterior posterior direction, that LV. We need to actually move the hands around on the chest until we find the appropriate place. So that's another thing that could be helpful. The third thing that could be helpful is actually your depth of compressions. We all know, even though the studies show that mechanical CPR versus manual CPR, there's no difference, but we know that our rescuers get fatigued. You can follow the excursion of the sternum during CPR to maintain adequacy of it. Nothing that we're going to get into, but just using M mode, following the sternum up and down, is going to tell you how well CPR is going, and you can tell when rescuers are getting fatigued so you can swap them out. And the final thing I'll say is there have been a couple cases that have been really, really good where the monitor reads asystole, and looking at the heart, you're actually seeing ventricular fibrillation because the resolution of transesophageal echo is just that good. So you could see ventricular fibrillation and shock that person where normally you'd see asystole, very fine VFib, and not shock them. So in cardiac arrest, I think it's a no-brainer. I think at the minimum, you should be using transesophageal during cardiac arrest. Those patients, although it's kind of grotesque to say, those patients are dead. And the only thing you can do by using transesophageal echo is give them a better chance at survival and ROSC by doing all the things that I just talked about. I'm done. Off my soapbox.
That was beautiful. It was like, it's well known that Haney Malamet's favorite things in life, it's like cardiac arrest number 1, like TEE number 2, and it's like cheeseburgers and his family 3 and 4. And so I just couldn't wait to ask that question because you were just like, you were so in the zone. It was unbelievable.
I love how you put cheeseburgers above his family.
It is actually.
I should have said In-N-Out cheeseburgers if we're going to be specific.
So many.
It's so good.
So
all
many
right,
cheeseburgers. All right, let's get some questions going, and please drop in your questions. There's not many questions here, but there's a couple. Let's see. We have. Here we go. I know someone that's going to answer this question. Transesophageal echo for heart measurements. Who likes to lecture on that? Mike?
For heart measurements? For hemodynamics or for
I
measuring chamber
I
size?
think that's what they meant.
I
Is
guess
probably
that's the
for
question,
pressures. Yeah. A surrogate for
Yeah.
pulmonary artery catheter.
Yeah, I think
That's a big heart.
Yeah. That's not normal. That's not normal. I think when you get really skilled at transesophageal echo, you can get really strong measurements. I mean, but if you can get adequate views of the pulmonary artery in particular, you can get a mean PA pressure, a PA diastolic pressure. So I think that's really great. We talked a little bit about the limitations with tricuspid regurgitation. So PA systolic pressure, I think, is not that great in transesophageal echo, but you can certainly get it. And I think you can get cardiac output and stroke volume very well. So I think it's very helpful. If you were to, I mean, this is going to sound a little bit bullish, but if you were to try to time someone doing TEE versus putting a PA catheter in to get this information, I think you'll get it faster with a transesophageal echo. But I think there are some limited views. I think certainly PA systolic pressure by tricuspid regurgitant jet, if you're facile with that, is probably limited. But I think you can get most measurements, and I think you can answer the question that you're looking for.
But it's also just one time point, right? So the benefit of PA catheter is that it's longitudinal, and so as you make interventions, it's easier to continue to see the changes.
Yeah, I mean, you can leave a TE probe in for a little while, right? As you're making adjustments, as you're adding ionotropes, if you're adjusting around medications or changing PEEP, you can also implant the transesophageal probe, I think, without really major complications. And you could potentially be preventing yourself from having eclampsia, or at least that's what my boss would love for me to say, right? So I think you are right. It's not an indwelling device. Are there indwelling transesophageal probes that you just sit in there and they're okay to stay in there for 3 days? Yeah. They give you a mid-esophageal 4-chamber view. I don't think that gives you all the information. The other thing, Adam, is what I'll tell you, if I'm being a tough guy here, is if you put a PA catheter in, you are getting numbers and you're trying to figure out what's happening based on those numbers. If you put a transesophageal probe in, you can not only get the numbers, you may see what's causing the problem and have a more clear diagnosis without further imaging. So if you have right heart failure, you can see the massive PE, right? If you have, that's very helpful. So, got you. How about that one? No, but it doesn't replace a PA catheter fully in every situation, but it certainly is faster, and it certainly can be an adjunct to what you're doing.
Yeah, gotcha. Let's
may also need it to get the PA catheter in the right place.
There you go. Right. Let's see, what else do we got here? All right, let's see. Randy's got some questions. Welcome, Randy. Let's see. What do you guys think about this one? Talk about management of VV and PA catheters. If you place it, shouldn't you be responsible for being able to evaluate the positioning as well as the patient progresses? Well,
I think he's saying VV ECMO versus the return in the PA as opposed to venous. So VPA ECMO.
Oh, I'm sorry, I misread that. My apologies. Mm-hmm. Okay.
So first off, I think before you guys even get into it, I think the concept of whether to do TEE for this or fluoro is interesting. I know we prefer TEE, but I'm not sure the literature supports that. What do you guys think?
Yeah, I mean, I've searched for this. I think TEE only guidance is pretty novel in this realm, and I think is doable. I think in terms of that's talking specifically about the VPA approach. But I think for to Randy's question, like you're doing the procedure, you could argue that you have a system where you have consultants who are readily available to help you with these things and evaluating position. But it just it adds so much to, patient care and the ease of knowing what's going on with that cannula and seeing where it is and facilitating you making adjustments in real time on a day-to-day basis when things can change rapidly if you're able to assess it. And yeah, I think TE offers other tools to do that.
Yeah, if you're putting in Avalon catheters, there's really limited literature to show that it's safe for placement. There's a 10 patient study, retrospective study, looking at five people who had it placed by transesophageal guidance and 5 by fluoro, and both had no complications from placement, but the patient population that had it fluoro guided needed that catheter to be readjusted because the jet coming out of the Avalon catheter was not going directly across the tricuspid valve, which is something that we're able to do in real time when we place it by transesophageal echo. So I don't want to paint a picture that it's like there's a ton of evidence saying it's safe and superior to do it under TEE. It's certainly faster, and depending on the bed, your fluoro machine might not fit underneath the bed, and that's often a limitation if you have to do it emergently at the bedside. So I think when you're looking at an Avalon catheter or TE, I think you have to have it because you have to be able to say, this patient who's now hypoxemic, is it because we diuresed them and now the catheter has changed in position, or someone rolled them to bathe them and the catheter is now in a different position? But if you think about yourself at 3 a.m. managing these really sick patients, when they crash, you don't have time to call your consultant to come and from home and do this. Very often you need to have the skill set. And so that's whenever I'm trying to convince someone of the benefit of it, it's that 2 or 3 a.m. conversation of if you had this ability, would it make your life and the patient's life better? And I think most of us would kind of calm down and say, yeah, it would.
Well said. Well said. Well, I think we got to the bottom of the questions. We're also a little bit over time, but I don't care. This was a great discussion. Had a lot of fun with talking to you both. Adam, you got any closing thoughts or questions?
Yeah, as I said, TE scares me, and I was looking at those views, and I immediately said to myself, I understand what that is, so I'm convinced. Tomorrow I'm going to learn TEE. That's it. Tomorrow.
Well said. Well, gents, thank you for being on tonight. It was really awesome. We'll definitely going to get you back on if people are really responding to the chat. Maybe we'll go through some views and actual TE using the simulator that we have, or maybe to talk about just anything else. But you two dudes are super smart, and it was really good to have you on today. So thank you for taking time out and being on the lounge.
Cool. Thanks for having us, guys. It was fun.
Yeah, thank you.
For sure. Well, there you go, Adam. Two smart dudes, or as we say around here, bruhs. Do you say bruh? Is that something you drop? Do you say, what's up, bruh?
Only when I'm around you, Haney. I like to.
Oh, really? Do your kids say bruh?
No, my son's been calling everyone dude. And so,
okay.
Yeah.
No, my middle one.
Except for Mama. Mama is not a dude.
Oh, okay. No, the little one calls us all dudes, and the middle one is bruh. And you know what else they said? I love this. I love lingo. Like, I'm really into it, and I encourage my kids to use all the slang possible. But my daughter, we're driving. She goes, "Dad, low key, I'm hungry." Have you heard this before? Low key?
No.
It's just like like a little bit, or like on the down low. But it's low key, whatever. I love it. It's my favorite.
That's awesome.
Yours are younger than mine, so I'll give you a crash course in the slang.
Yeah. Well, it may change by the time they get older, right?
It's always changing. You can't say cap anymore. Do you know what cap is?
No, I don't know what cap is.
Cap is when it's like if someone says something that's wrong, you're like, that's cap. And that's already old. You can't even use it anymore. So there you go. That came and went. You didn't even know.
Yep.
Yeah, Adam, I'm going to get you on TikTok, and you'll know all this stuff. Don't worry about it.
Oh, I can't wait.
It's all good. Bro, that was that was a good episode. Episode number 16. Yeah. And what do we have planned for episode 17?
I'm actually this may be the one I'm the most excited for. We're going to do some tox cases, and there'll be, I haven't decided how many, 3 or 4 vignettes, classic toxidromes that we all see and have read about. And we're going to have a toxicology ER superstar, and as well as a critical care pharmacist. And they're going to talk about it from kind of two different approaches. And I think it's going to be really, really good.
That's awesome. I'm really excited about that episode. Tox is one of those things that it just sort of exists and you're like, everything's good until you need a toxicologist and you call that person up. They're some of the smartest clinicians around, whether it's a pharmacist or a physician. They're really some of the smartest people. They know all that biochemistry that I worked very hard to forget since medical school. That's what they're good for.
Absolutely.
All right. Well, just remember one thing. Eat clean, bruh.
Thanks, Randy.
Always coming through. Yeah, thanks, Randy. I have an idea for a show that I'm just gonna plant the seed here live. I'm gonna say that we have a show where we have the audience vote on a guest that they want to host the show.
Yeah, this is along the lines of like the reverse lounge, right? Where you and I are.
Well, yeah, we take the night off and then we have a guest come on the show. Like, have you seen Jimmy Kimmel's now on vacation? So he has all these like guest hosts coming on. I say we have the audience pick a guest host that they really want. We get that guest host on and they can do whatever they want with our show. And well, I hope they don't make it better than what we do, but at least to the level of what we do, if not better. Sound good?
That sounds good. I'm in.
All right, cool, man. Adam, always good to see you, and thanks again for such an excellent lounge. And I'll see you tomorrow doing TEs.
Absolutely.
All right, bruh. I'll see you later.
I'm not going to.